I'm Nick White. I'm a professor of tropical medicine based in Mahidol University in Bangkok, Thailand, but also in Oxford University in the UK. And I chair the Wellcome programs in Thailand and Vietnam. And most of my life has been living and working in Southeast Asia, mainly on malaria, but also on a variety of other infectious diseases.
Can you tell us a little bit about the global health landscape to begin with?
Global health has evolved out of something we used to call tropical medicine, I think, and it reflects the health and the delivery of health, study of health to populations predominantly in low resource settings, and those low resource settings are predominantly in the tropical regions of the world. It's an emerging field, expanding rather rapidly, and I'm going to give some reflections based on my own personal experience. They'll be somewhat curmudgeonly, as befitting my years, but I think there have been many good things that have come out of global health. I mean, humanity has done very well in recent years. Life expectancy has improved in most countries. The quality of life has improved. Our other animals have not done so well.
Who do you think are the main actors in the field?
So there's a complex mix of actors in global health, ranging from the governments of the countries, the NGOs, non-governmental organizations that are involved in health delivery, of course the population itself, and that I think the population is often under appreciated in this whole arena. Then we have industry, we have academics such as myself, we have international organizations, notably the World Health Organization, but several others. We have donors, we have funders, all of these interacting ostensibly to deliver improvements in global health. And I would say that overall there have been substantial improvements, but there are things that are not good as well.
So can we talk a little bit more in depth about some of these actors, perhaps starting with academics? Since you're an academic, what do you think is the role of academics in this complex landscape? What do you think you do, and what do you think you should do?
So we do need academics in all areas of medicine, but particularly in global health. We need academics to conduct research which would inform policies and practices. What's happened has been an explosion in global health. You know, universities all over the world have seen, I think, a business opportunity, and are opening global health departments, units, and what have you. And so we have an exponential increase in the number of global health people. Quite what they're all going to do in the future, I'm not quite clear. But I think what we should be doing is studying these diseases, these global health problems in the places where they occur, and providing solutions that are practicably, can be delivered, are affordable and available. And that's a challenge. And I don't think you necessarily have a good balance at the moment. The average global health researcher in my jaundiced eyes is usually seated behind a computer, not at the bedside or in a village or peri-urban area where health is poor. And I think we have a dissociation, therefore, between the reality, the unfortunate reality, the unpleasant reality of living with nasty diseases and dying young and suffering for much of your life, and the somewhat rarefied atmosphere of often universities in resource-rich areas. So we need to bring these two together. I don't want to be overcritical of many of the areas of global health research, but I do think we need a better balance. In summary, I think we have too much speculation, too much mathematical modeling, too much derivative prediction. We have lots of very good research on molecular biology, molecular epidemiology, and so on. And we have relatively little clinical investigation, clinical trials. The old disciplines, if you like, of parasitology, pharmacology, pathology, physiology, in fact anything beginning with a P, these are things that are not done nowadays. And that, I think, is to the detriment of the efficiency of global health, because we haven't got unlimited funding for all this. In fact, we are in a very tight situation for funding for global health. So let's spend it wisely.
So why do you think that's changed, that the P's are less emphasized and there's more of some of the other things that you mentioned? Or why do you think that's happened? Or what's driven that evolution?
I think that evolution has been driven by really the expansion of global health as a discipline in resource-rich countries. And therefore, you have to fill that discipline. You have to fill it with teachers and with students and so on. There is going to be some connection with the unpleasant reality in the lower resource areas, but that is often a rather tenuous connection. So these people have to do something. Now, it's also quite hard to do clinical research in tough areas. You have to go there, you have to be there, and you have to often overcome a number of different obstacles to actually even start your research, if you're lucky enough to do that. It's hard. And clinical medicine, bedside medicine, is tough, and people don't want to do it. It's easier to sit behind the computer and do predictive modeling on what that situation might be. But of course, that modeling is no good if what you put into it is wrong.
What about some of the other actors? For example, policymakers. What do you think they're getting right? What do you think they're getting wrong that could improve?
So the policymakers, in other words, the governments or the international organizations such as World Health Organization, who provide guidelines which are influential to policymakers, are largely or often political appointments. And in low resource settings where the human resources are limited, it's quite often for the people involved to not be technically very competent. In fact, technical incompetence pervades global health, unfortunately. If I was to say what's the one thing that upsets me the most, it's technical incompetence at every level amongst all the actors, the funders, the donors, the national control programs, not just malaria, that's my bias, even the academics. But the question is specifically on policymakers, and I think we as academics often fail to explain well what we have found and to translate the science. But the critical determinants often of policies and practices is money. And so really the donors have a huge responsibility here to facilitate sensible, good policies and practices. And let's also talk about something which is never talked about in public, which is corruption, and to a lesser extent bureaucracy. These are major problems. We know that in the governance across the world. I mean, the corruption's everywhere, and global health is not immune to this. So we have to be realistic, and I think that the reality, the true reality, is often not evident to those who give the money. Much of global health is funded by the resource-rich countries through funders who give, either through governments, international agencies, or whatever, who give money to support global health. That's hugely determining in what happens. So for me, I'm not blaming policymakers for making mistakes or giving wrong policies, particularly. I would say that the global health policies which we get wrong, there are often multifactorial reasons, but the funders take a huge responsibility, and the academics. We don't explain things properly.
Would you be willing to give an example of how you've dealt with some of these issues yourself? A case study as an academic, how you dealt with policymakers, what you did, which you think was right, Would you think with hindsight, I should have done that differently?
I'll give you two examples in malaria. One is a good one, is a bad one. So in the early 2000s, malaria was undoubtedly killing probably more than 1 million children each year. And that was because all across most of the malaria-affected world, the current policy was the use of drugs that did not work, mainly chloroquine. Chloroquine had died many years before in many countries, but it was still being used because it was cheap. And gradually, a groundswell of evidence, opinion, and anger culminated in accusations to international agencies of medical malpractice, which actually it was. And that was when, and the policymakers in the countries were part of that groundswell. There was a concerted movement, both amongst academics, non-governmental organizations and policymakers saying, look, this is wrong. And the funders switched. That was good. And it worked. It took too long, but it worked. And there was also some brave individuals within the World Health Organization who engineered the possibility of making that change. Credit to them. Let's take another example. So in malaria, there's an approach to controlling malaria where you give everybody drugs. It's called mass drug administration. Got a really bad name, and it became a sort of toxic commodity. But actually, there were reasons for that. And so we, in our research, provided what we thought was a good scientific argument as to why this giving mass drug administration as an malaria elimination accelerator would be a good thing. And I failed completely to convince anybody of this. And it took the usual 10 years before finally policies changed. I would say that I'm rather bad at providing scientific arguments that are persuasive to policymakers. And I think that's just my own failing. And I'm not saying that it's these weren't my discoveries, by the way. None of this is my discoveries. These are all research, almost all, unless you're Einstein, almost all research is a collaboration. It's everybody putting their ideas together and then trying to translate those ideas into something good.
So we've talked about some of the main actors. We talked about academics and funders and policymakers. What role do you think industry has?
Industry has a pivotal role because first of all, no nationalized drug company ever invented a new drug. So fortunately or unfortunately, depending on your political perspective, we are in a position where industry is necessary to provide the products to improve health. And those products are ranging from diagnostics, treatment, machines, equipment, and so on. And so industry plays a very important role. But industry is, by definition, profit-driven. And if the recipients haven't got any money, there's a problem. So the business model doesn't work unless somebody else puts the money in. And that's what happens in global health. Who puts the money in? It's the rich countries. So again, the funders. So the funders are responsible for directing the largesse of the wealthier countries towards appropriate support for industry. We have to engage with industry. And we have to provide, I would say, a mixture of carrot and stick. We have to provide, they have to make money, but they also have to be encouraged not to ignore the problems of global health. A lot of, for example, big pharma have just simply said, there's no money in global health, we're not going to do it. We'll make loads of money in the rich countries and we'll forget about the people in the poorer countries. That is something where internationally we need to provide stick. And I think there should be incentives for industry to be involved in these areas where they're not going to make large profits, but they're going to do global good.
And what sort of incentives might these be? If I was an industry person, what would you say to me?
I think the incentives, there are a number of different ways of doing it. Let's take a drug. So, for example, the United States Food and Drug Agency has what's called a voucher scheme, a priority review voucher, which basically is a way of rewarding a company for developing something which hasn't got necessarily a profit angle to it, or affects only a small group of people, or low resource settings or whatever. That's a carrot. That's a positive incentive. Here you are. You can take this voucher, and on your blockbuster, you get a few extra years of patent protection, effectively. You can have tax incentives for developing. Companies can have tax incentives for developing things that are good. I think you can also appeal to good nature. Now, you may be cynical about that with industry, but I think there are some industries who feel that their public image is important, and there could be things like a green stamp on the side of a packet or whatever that says we do good things, just like we have for foodstuffs and so on. They're ethically produced foods. I think there are a number of ingenious ways in which we could incentivize industry, and also perhaps punish them a little if they're not being as generous as they should be.
What do you think funders should be doing or not doing?
I think funders are very, very important. They pay my salary, they pay your salary, they pay everybody in global health receives directly or indirectly support from international or national funders. And we should be very grateful for that. But that puts a huge responsibility on the funders. And in my personal experience, the level of technical competence in funders is usually very low. They may have processes to get expert advice. I have never been particularly impressed by that. The people who work in funding agencies usually have little or no direct knowledge of the problems they are dealing with. They are easily seduced by either good advertising from scientists or skillful representatives of the recipient organization. Let's say it's a country who depend entirely on squeezing as much money as they can out of the funders. All of this, who's lost in all this? It's the recipients. It's actually the people with the diseases. People talk about process indicators and so on, but actually what matters is, are you delivering an improvement to health to the people who need it? And how do you find out about that? And if you really are ignorant of the problem, ignorant of the science, ignorant of the biology, ignorant of its unpleasant reality, then you can't be a wise donor. So I think there is a huge responsibility on funders to be better, do a better job. I do not feel that they do a good job, personally. I can say that now. I'm retiring. I couldn't say it before. Everybody in the field is dependent on the largesse of funders. And so, as in any medieval state in Italy, you don't criticize the boss. And so you don't criticize the source of money. So the funders are in the position of a dictator. They are given what they want to hear in the hope that the recipients will get more money. And so they don't get a good view, an objective view. They have to work really hard to find out the truth, and often they don't. So I'm sorry, thank you very much for funding me for my career, but really, I think you need to do a better job.
What advice would you give to an early career researcher who's starting out in global health research?
Don't listen to anything I say. That would be my first piece of advice. The second piece of advice would be, this is a really important area. If you're good, you'll do some good. And don't be put off by the huge number of bureaucratic, irritating, and other obstacles. As a researcher in medicine, for example, if in most other areas of medicine you have a very limited opportunity to really make an impact on people's lives, but in global health you can. So I think it's a very, very exciting area. But go there and do it. Go there and feel it. Go there and breathe and live the problem. And then you might be able to understand how to solve it. You can't do that remotely. You can't do it based on, Google and models. It's a real problem, and you need to touch it and feel it and know it and understand it. And don't try and, these are big problems. They're complicated. It's hard work. You've got to understand them. There aren't quick fixes in almost any area of science, and global health is no exception to that. It's hard to be good at it, but it's worth the investment.
What do you think is the future of global health research? Where do you think it will go, and where would you like it to go? What would you like to see?
Well, I would like global health research to be more efficient and to translate into better improvements in health, because I don't see a lot more funding money coming for global health. I think the danger of the current situation, where the discipline has expanded, but I would say the efficiency and effectiveness has declined relatively to the investment, that donors will get tired. Or people, because ultimately if it's money's coming from government, it's people, it's taxpayers. And we don't want people to think this is hopeless. It's no point in throwing money into these countries or places because it's not going to do any good. That is a story that must not be told, and we need to be successful. So I would hope for greater success in global health, and I would see that through better technical understanding of the problems and therefore more efficient solutions. We must keep and maintain the important narrative that it is worth giving for, and who's giving? The rich countries, the people in rich countries. It's worth giving because this will be beneficial not just to the recipients but to us all. We will be a healthier and happier and therefore hopefully safer world. So it's in everyone's interest to invest in this area, and that means that we in global health have got to do a good job.